Let me now invite Dr. Jahangir Kabir to argue against the topic of bladder preservation for muscle-invasive bladder cancer in 2023. Over to you, sir.
Chairpersons, distinguished audience, also my previous speaker, I congratulate him to stay in the debate. And he made my topics very easier because he himself described a lot of limitations and buts and knots of the bladder preservation therapy. So I just go through some of the points so that you can easily understand in 2023 now whether this is practicable or not. Maybe in future, I don't know. Bladder cancer is the 10th most common malignancy in the world, and MIBC accounts for 25 to 30% of the diagnosis. Radical cystectomy is still the gold standard for the treatment of MIBC. BPT has been coming up as a new modality, but not suitable for all patients. What is bladder preservation? We have already learned that BPT involves trimodal therapy, complex, and maximum TURBT, and concurrent chemotherapy and radiotherapy. BPT used to be an alternative for medically inoperable MIBC patients, but currently, nowadays, some of the people, they are doing BPT in a operable MIBC patients. NCCN guideline proposes BPT as a viable option for cystoscopy candidate, but there is a disagreement. UA guideline emphasizes that the importance of patient selections. So how you select the patients? You see, what you can say, solitary, small, low volume, less than 5 centimeter tumor, T2 disease, no CIS, no hydronephrosis, no lymph node metastasis, timnal embryo to complete cure, favorable baseline bladder functions, normal or favorable performance status. So you can see that how many no's of it. So before selecting patients, we must be very careful. Unfortunately, only 10 to 15% of medically operable MIBC patients meet the ideal criteria for bladder preservations. So we must be very careful about it. So now there are three components of bladder preservation therapy. One is surgery, which is TURBT, another is radiotherapy, and along with concurrent chemotherapy. So let us talk about few points on it. Complete TURBT in MIBC is not easy to perform. Maximum TURBT, that is visibly portion of bladder tumor, is performed with a stronger prediction. If you can perform it, is both oncological control and TMT success. But residual cancer can present 30 to 70% of the patients on repeat TURBT signifies TURBT failure, TMT failure. So you can see that there is a clear disagreement between the groups. One of them says that after maximum TURBT, you give some radiation 40 to 45 gray, and another group says that full dose. And after wait for some time, evaluate it. Again, in case of failure, you go for radical cystectomy. Again, radical cystectomy is the here to actually help the patients. So chemotherapy, you cannot really, you can really say straightforward. There are a lot of contraindications of patient-for chemotherapy, like severe bone marrow depression patients, compromised kidney functions, pre-existing medical conditions, increase the risks of adverse reactions. So potential some side effect of chemotherapy. You have to think that the nausea, fatigue, immunosuppressions. So you have to balance between the things and before you start with the chemotherapy. So how you assess the responder or non-responders? CAT response is assessed on cystoscopy, urinary cytology and radiological examinations and transmitted dissection. Again, the surgery, you have to need the transmitted biopsy of the bladder mucosa. Significantly worse survival outcome in CRT non-responder as compared to CRT responders. So recurrence, 11 to 19% of MIBC recurrence, even if MIBC recurrence occurs, even after complete remission of cancer after TMT. So most of the MIBC recurrence develop at the original site from the smaller foci which escape the post-CRT evolution. So CRT, what it does? It delays the radical cystectomy. It is difficult to predict the CRT response. Adding to CRT response delays the salvage rectomy, which affect the prognosis. Outcome of salvage radical cystectomy is worse in CAT non-responders. Salvage radical cystectomy after the BPT preclude orthopedic neovalvular reconstructions. So these are the points you have to consider. So what is the radical cystectomy? Radical cystectomy can treat the patients with T2 to T4 disease. Why we have seen the only T2 disease you can say. Associated CIS is not a contraindication. Hydronephrosis is not a contraindication. Multifocal disease is not a contraindication. Radical cystectomy gives the chance of lymphadenectomy, which has a diagnostic and therapeutic benefit. Salvage radical cystectomy is still available to rescue the non-responder to bladder preservation therapy. So my friend, you must be very careful picking up a flower with thorns. I wish I can treat all the patients with MIBC with BPT-like treatment, but in really it's mile to go. Gold standard is a method, procedure, or measurement that widely accepted as being the best available to test or for a treat or for treat a disease. I believe in 2020-23, radical cystectomy is still the gold standard. Thank you very much for patient hearing.